welcome to the Aaron Werner podcast on iCode Media. I am here today with the Dr. Jenny Drake.
Hey.
Jenny is a longtime friend of mine out of Tennessee, and I'm going to do my best not to say Jenny a lot of times on this because that's the only thing that runs through my head. Jenny, I can't believe it's taken this long to get you on here.
I know. Well, I was waiting for my invite when it started, but hey, I'm just glad my number finally got called. 4,753 is okay with me. It's fine, Aaron.
Well, I had to build it up and make sure it was worthy of the Jenny Drake to join. Yeah, absolutely. So, Jenny, before we jump into to chatting today, give us a rundown of who you are, what you do, all that good stuff.
Sure, yeah. So I practice in Murfreesboro, Tennessee. We have a 6-doctor practice, multi-location, and do a little bit of everything. We're primary care, but very heavily in dry eye disease, that sort of thing. So I was super excited when Lacrifill hit the market.
Yeah. So, and that's what we're going to jump into. And I didn't tell you this, and I didn't think of it till now, but I'm going to put you on the spot a little bit because I think when I really got to know you was when we were coming back from Scotland, and you didn't quite make it.
Yes, I am. I guess I'm notorious for this story. That's exactly right.
So, yeah. So the quick version of it is basically your daughter wanted to come earlier than expected, right?
Yeah. She decided that 25 weeks was long enough to marinate, and flying home from Scotland by way of Paris, I went into labor at 25 weeks pregnant, landed in Dublin, Ireland, and gave birth 4 minutes after arriving at the hospital to a 1 pound, 13 ounce baby girl.
So, and it's super healthy and feisty and all that kind of
great.
Good stuff.
Yeah, she is great.
So
9 years old and going on 18 now.
You got one of those too?
Yeah, I sure do.
Yeah, there.
Every mistake I ever made is being paid back for tenfold.
It's not that they don't tell you that when you're like wanting kids.
That was not in the book. That's right.
No, definitely not. But the really cool part of that story, one is that it happened and now you're notorious for it. But just the community support that rallied, and it's nice to see just whenever there's an opportunity for community to come together. It's a pretty cool story.
Yeah, there were 32 doctors who filled in pro bono for me during that 3 months I was away. So pretty amazing part of the story.
That is a huge part of the story. And so cool. Didn't mean to put you on the spot, but
no, you're fine.
It's too cool of a story not to share for those who haven't heard it. So what I wanted to chat with you about is Lacrifill, and because it's plugs have been around, right, as a part of a dry eye treatment for a really long time before I became a doctor.
Sure.
And not much has changed. I mean, they kind of changed shape, maybe changed color a little bit, and novel ways of having them preloaded so you could put it in easier. But I think it was still dilate and shove a plug into the punctum and hope that it stayed there long enough and the patients tolerated it well enough and whatnot.
We didn't know if we wanted to stay or fall out.
You didn't want to stay fall out, right? And are they going to like me? Or are they going to not like me afterwards, right? And there's a couple different ways of doing it. And then it was kind of in vogue when I graduated school to not do plugs right away because we didn't want to keep inflammation in the tears in the eye, so we had to get rid of the inflammation and then go to plugs.
Right.
And then it came lots of other fancy toys that we bought to treat our dry eye patients.
Sure.
But now we're back with a non-plug filler. I was going to say a non-plug plug, but it's not a plug.
Let's go filler. I like it.
Let's go filler. Yeah. So for those who haven't heard of Lacrifill, give us kind of the real quick version, how you explain it to patients.
Sure. So I tell patients that it's made of hyaluronic acid, which your body makes anyway, so we're not putting a piece of silicone into anymore. We're using something that is great for the ocular surface. And I explained to them that this is more a full fill. So with the punctal plug, like you said, we were just kind of sticking one in there and blocking the top. This is going to fill up more completely the system there. And so I kind of show it to the patient. I'll squeeze out a little bit whenever I'm prepping the Lacrifill, and I'll show it to them. You can move it around in your hand and feel that this is just a nice soft gel. Patients really like that. And the whole procedure, I feel like patients are very very much put at ease when you talk about, I'm not making an opening, I'm using an opening that you already have,
Yeah.
and I'm just filling it up. So it goes very, very well with patients.
Yeah, I've learned that they don't like the word dilation when I say
They don't.
it.
I try to leave that
yeah.
out of there. Uh-huh.
Yeah, I learned the hard way that you're gonna do what? No.
What are you about to do? That's right. Excuse me.
Cool. So before we jump into how the ins and outs of how you found that you use Lacrifill, walk us through your dry eye clinic. I'm always curious how patients or how doctors manage dry eye clinic. So starting from the comprehensive exam, your managed vision care exam,
Sure,
or
that's
cash
right.
pay
Yeah.
if you're
So we
lucky
do a
enough to
lot.
have.
That's
Yeah.
it. We do a lot of managed care. So we utilize the speed score questionnaire. I liked that one because it was shorter and to the point, and I can just generate a real quick number on somebody. Is this something that you suffer from? And so I use the score of 8. I know some people use a little bit lower, some people use a little bit higher, but anybody who scores at least an 8 is going to have a conversation with me about their eyes and their dryness. Contact lens wearers, I think, is very much low-hanging fruit to just have the conversation. They're so afraid that you're going to take them out of contact lenses that I think they're really afraid to talk to you about their symptoms. And so I'm very direct with those patients. Like, I know you want your contact lenses. I'm not trying to take you out of contact lenses, but if I could make something better, talk to me about it. So, end of the day comfort. How far are we making it?
Cool.
Those sorts of things.
Nice.
And then, so in a comprehensive exam, I'll often do imaging that day. And everybody does it a little bit differently, but a lot of times we'll gland image that day. And I start everybody on some form of treatment, and the main reason I do that is because I'm going to make you come back. I think sometimes when we're just like, hey, here's your routine eye exam stuff, come back and see me for another appointment, sounds different than, I want you to go ahead and start these omegas and warm compresses. I'm going to see how well you're doing with that at your dry eye evaluation in 60 days. Here's your little slip to get this at the front. See you in a couple months. And so I give them homework. I have a nice little sheet, a little checkoff sheet. I love to make corny Southern jokes about, you're the first person who's ever had this. Here's my sheet that's pre-printed with 700 things that you might have to do. Check off the ones I want you to do and give it to you. And so, so they make it to the front with homework, and we have a really good show rate on our dry eye exam because of that.
So this is interesting. I want to break this down a little bit. So, because we do it slightly differently, and I don't think there's a right or wrong way.
Sure. Mine's right, but go ahead.
Yeah, yours is right. Yours righter. Is that a word? Righter.
Just kidding, friend.
Yes. No, actually, so yours is the right way because you've got it spelled down every step of the way.
Sure.
Right. I love the phrase or expression that everybody has a system, but most of our systems suck because we haven't
Right.
thought through it real well. Right. Clearly, you've thought through it, so I want to put some just time constraints on it.
No, sure.
Because you've either got the camp that does only the routine wellness exam day of, and then we're going to bring you back 100% for everything. I'm not going to talk to you. Right. That's not what I'm getting paid for today. I'm not going to do anything more.
Right.
And then we've got the camp that does everything all at once because why inconvenience you to make you come back? I'm just going to inconvenience everybody after you.
Right.
I'm going to put myself behind in the schedule, but I'm taking care of you now. And then you've got you right in the middle where you do enough to generate the next step.
The why.
Right. The why. Yep. So you see them for their comprehensive exam, their wellness exam, and then you said you image that day. Do you kick them back out of the exam room, send them back to the techs and say, I want mammography? Do you do it on everybody?
So it depends, right? I almost find that it's like the psychology of dry eye, right? So a patient comes to you and they're super symptomatic and they have all these things that they want to tell you. I don't have to image that patient today, right? That patient, I'm going to tell you what to do, see in 2 months, let's do this. That person who's kind of like, but I'm fine, but I'm great, you know what I mean? Like if I need to do imaging today to get you to come back in 2 months, that's the person I'm imaging.
Gotcha.
Yes.
Okay, that makes sense.
Yes.
And
a lot of my techs will skip ahead, see the 8, and they'll do it. That's my favorite.
Yeah, are you listening, techs?
I already have it.
Yeah.
I'm spoiled. Mm-hmm.
Yeah, you can have them listen to this and be like, hey, shh.
Right.
See that and jump in. No, it's and having that process is important, right? We joke, but just knowing that's part of the process. When you see this, then you get that. So let's back up even further. So does everybody get a speed score or a speed test?
Well, I say everybody. Everybody, I think they do 12 and up.
Okay.
Yeah.
So
And
some
that's
of the
because
kids.
they get a COVD score. And I think they just don't want to bombard people with like, here's 800 documents about all the things. And so I have to elicit the dry eye complaints younger than 12. Not saying we don't ask, but it's just how many papers can you give one human? And so that's kind of how we delineated with us. Anybody 12 and younger, do this one. 13 and up, do this one. It's just the line I drew.
No, I think that makes sense. And if somebody has a different age, that's fine. Just have a clear strategy.
Yes.
So I like that speed score. And then if it's an 8 or worse, then hopefully they do the imaging. Right?
Yep.
I like it. Are you doing mammography? Are you doing fluorescein staining images?
We have a couple different ways we do it. I have leaned more heavily now on magnetic. I'm using magnetic a lot. Topographer, mammographer, all in one, and then I also have a My Box that I can use as well. So,
Okay.
Yeah.
Cool. So give them that picture. I like that.
Right.
Right, and then you get them in the room. It's interesting you said some of them that come in with just full complaints, and I agree. Those are the easy, low hanging fruit.
Right.
I found my mammography helps some, but I found even more just poking them with some dental floss, because I've been surprised how many are neurotrophic, right?
Yeah,
and have lost
exactly.
sensation, which means even if I show them a scary picture, like, yeah, I'm fine.
Yeah, right.
Right. I try to elicit that extra pain. I'm like, this should be hurting you.
Right.
And it's not.
And it's not, exactly.
But I like it, but the goal is not to do the test. The goal is to get the why.
That's exactly
You've
right.
mentioned that.
That's exactly right.
Yep.
I want you to come back in 2 months. I mean, that's the whole point. I think that's where the schools of thought align, right? Is we all know that we need more than a comprehensive exam. We need a dry eye evaluation. Where we might differ slightly is I think to get people to come is important. And that's where I found that implementing some form of treatment, if you just do something and then follow it, people are much more likely to come back to see what you think.
Yep. I like that. It also makes it about them, right? I'm helping you now.
Exactly.
And you're the hero of my story, but we got to just check in.
You're not coming back because it's convenient for me. You're coming back because I need to see how you're doing.
Yeah. Well, you're like the Yoda to Luke Skywalker, right? You're trying to help them become better.
That's right.
So I like that. And why 2 months? Why not sooner?
You
Why
could
not
do a
longer?
month. You could do 3 months. You could do literally whatever. I shot the middle.
Okay.
I tend to be a shoot the middle kind of gal.
That works.
2 months feels good.
It's that. And is it pretty much standard that you're putting them, initial treatment is Omega and warm compress and out the door?
Yes, I do. Omegas, warm compresses, drink more water uniformly.
Drink more. As I'm sitting here drinking a Diet Coke.
Yeah,
You just
it's
made
on
me
the
feel
check.
bad.
It's on the checkoff sheet.
It's on the checkoff sheet. I might have to steal this checkoff sheet
more
from
than
you.
anything, all this stimulates conversation, right? Like, oh, my doctor actually cares that I am drinking Diet Coke instead of water. Like that. That's part of the conversation. And what it has helped too is I'll start laying the foundation in my little checkoff sheet, because all the stuff that I might do next time is on that sheet, right? And so you can kind of start the conversation, and you can look down this list and see that there are other things that we can address if it is not better. Or, if I'm not seeing what I want to see, then here are some things that we can do next. And that's where my IPL conversation can start. My thermal expressions, all that is on there. And it can just begin the conversation. Because what I found too is the first time you tell somebody something, they have to process it. And so if the first time somebody's ever heard that that'll be $2,500, here's what it's going to look like. The first time, a lot of times you get a no, or I need to think about it, or whatever. So I just switched from now I have a 60-day delay instead of a 12-month delay, because I started the conversation now. And so a lot of times what will happen is I'll say, remember how we talked about that IPL that was $2,500? I really think that needs to be our next step. And they'll be like, well, you did say that. And, I talked to my husband about it, and let's do it.
Okay.
You said you were going to make me pretty, so I'll pay it.
I might have to take you up on that. I need all the help I can get. You didn't have to agree so quickly.
I thought you were talking about the patients. I didn't know you meant Aaron. I thought you meant this human that we were pretending with. No, Aaron, you're already beautiful.
God, you're funny. Well, I like it. So you're very strategically planting a bunch of seeds.
Oh, it's all manipulation from the very moment of, hey, how you doing with my southern drawl? I mean, it is all master manipulation.
So for those who are listening and just said, I'm not a manipulator and I hate that, let's shift it slightly to you're creating the experience.
Why
Right?
does manipulation have to have a negative connotation?
It just does.
Manipulation is what we do in conversation. It is what we do in parenting. It is what we do in life. Why does that have to have a negative connotation? What we're doing is steering our patient in the direction that we want them to go. If you don't like the term manipulation, choose a different one, but that's exactly what we do in every conversation, is we steer it the way we want it to go, whether it be by a pair of progressives, whether it be to do dry eye therapies, whatever. You want the patient to see you as their trusted advisor, and here's what I want next steps to be. And you set that foundation with very clear directives on what you expect, and when you don't get it, you make moves.
We just had a master class from the Jenny Drake. Yep. No, I agree 100%. Right? It's
Right.
We're driving the bus, and I think you can use that for good or bad. Right?
Right.
You can steer, and we all know colleagues who do this, very few, but who are very financially driven and steer people to
Sure.
things they may not need.
Right.
Most of us steer patients to things they do need. They may not appreciate that they need it at the time, right? But it's our job to help them understand. And it might not even be this, putting a glaucoma drop in once a day. That's
Exactly.
kind of a pain in the butt to remember how to do.
That's
I hate
it.
drops.
And
I
it
do it
stings,
for a
doc.
living.
I don't want to do it.
Yeah, I don't want to do it. It stings. I got to pay. I got to remember to do it,
Right.
right? So steering the bus that way, manipulating them into understanding that
That's it.
there's additional benefits. So you're manipulating, setting that expectation, right? Setting the
exactly right.
experience you want them to have, and really planting the seeds early so that they come to when you're ready to harvest them.
That's right.
You know they're already kind of starting and growing. So I love this. Now you get to the to take our same fictitious patient, right? You put them on the omegas and the warm compresses, and you tell me not to drink my Diet Coke and drink more water and all that good stuff, right? Probably that second visit. What do you do? Right,
Well, that's where the fun
6-day
happens,
visit.
right? Because this is very much patient to patient. So this could be where Lacrifill makes a ton of sense. This could be where an IPL starts, maybe both. But I like setting up visit 2 for not only are we going to evaluate your dry eye, because that's really truly the dry eye evaluation, right? That's when we're going to do all the extra steps to kind of figure out what next steps should be. And then, I tend to follow the patterns, set out a little bit deuce too. I'm not going to pretend to know every single in and out of it, but I try to kind of follow the steps of if I want a membrane, right, I know that I got to jump through the hoops to make that happen. If I want to do an IPL, I've got to set the expectations to the patient to make that happen. But step 2, visit 2, I'm really ready to take some action. I'm ready to do something beyond an omegas and a heat. And let's make a patient feel better. That'd be when I would prescribe an eye drop if I were going to do a Xiidra Restasis, that sort of thing. Something is happening at that visit that we're going to again monitor. Most of the time at this point is 3 months. There's no magic as to why I picked 3 months. It just tends to be kind of how my brain works. That's enough time for something to work, in my opinion.
Yep.
3 months is a good amount of time to try something. You could do 2 months, but then you have to wrestle with yourself. Has it just not been long enough, or is it time to do something different?
So, I like it, and the quarterly kind of falls in with every other
That's
thing,
right.
right? It's a glaucoma management. It's seeing kids on myopia management, right? 3 months is
It's just a good amount of time.
a nice time. I like that. It's easy for the staff too, because when somebody says, "When do I need to come back?" they don't have to always
It's
look and say,
consistent. Yeah,
"It's
exactly.
exactly that system." So I totally agree with you on that. That's the dry visit, that second visit. We do the same thing where we dive deeper, do some additional testing, and then kind of shift. Now, we've always pushed punctal occlusion to much further down the treatment path, right? I want to take care of inflammation. I want to, get you on a myoptylite or on a lipoflow. Like I want to do something more. A membrane if I need to. Where was prior to Lacrifill? Where was kind of your idea on punctal occlusion, and has it
I hated
changed?
punctal occlusion. Can we say that? Can
you
say
say
on
what?
there it sucked, and I never had the size I wanted. Even if I thought I had the size I wanted, I never had it. So I'm in here dilating somebody's puncta to either drop it into no man's land or it to not fit. I avoided punctal occlusion like the plague. I would do literally anything else under the sun to not punctal occlude. And so Lacrifill is beautiful for that, right? Because I was missing out on all that market. I was doing all and I own them. I mean, I have them. So I was buying all the 2s and 3s and 4s and 5s, but I hated to. I flicked them across the room. I cut them in half. If I tried to use the ones that melt as you go, right, I'd cut them in half with my forceps. I hate them things.
I am sure you are not alone. And,
So yeah, it was really far down the list.
Okay.
And now we have a cover. You know, how many times do we get to say something is covered? That is probably one of my favorite things about this is everything I talk about is thousands of dollars, right? Yeah. So I can put you on this med that's thousands of dollars. I can do this procedure that's thousands of dollars. You know, what do you want to do? Yep. And now I finally have a step in between, and that's kind of where I plan on placing it for the most part, is it's the in between, right? Like, let's try the one that they'll pay for. Let's try that. Yep. And then from there we'll make decisions.
Yep. I like it, because we've kind of ended up in the same place as well, right? It's in what we've told patients and what I've told them, because I didn't hate plugs as much, right? I enjoyed the challenge.
In your hate.
I was less passionate. I enjoyed the challenge of getting the silly thing in.
There you go.
But I don't think patients enjoyed it as much.
Did you super glue it, or did you put a little piece of tape over it, or what did you do to keep it in?
Pray, a lot of praying. Right?
Right.
And there's a lot of judgment on elasticity. Right. And there's a lot that went into it, right?
That's
measuring
right.
it and being like, well, you measure a 2, but maybe I should put in a 3, or maybe the 2 will work, right? So I enjoyed it. Like I said, I don't think patients enjoyed it as much.
Yeah.
And they certainly didn't like it when it fell out and we had to redo it again.
Right.
That was always a pain for them.
Surface, or it tilted in, and
rubbing.
all the things.
Feel something rubbing, you got to tap it in a little bit. Or the ones, the intercannulicular ones that I didn't like those as much, just because should we need to take them out, I never wanted to deal with it, right? And maybe I'm a little bit too worrisome and conservative on that, but I didn't want to make a small problem bigger if I didn't have to. But I always like the idea of keeping tiers that we have in the eyeball. Right? That made sense to me. So yeah, we now, like you, are very much place Lacrifill in the practice much earlier in the process, as hey, we still need to address all the other issues, but let's keep the good stuff we're making.
That's it. I like it.
And it worked well. So for those who haven't used Lacrifill, run us through the process of using it on patients.
Yeah, so it's completely simple and easy. If you can do a punctal plug, you can definitely do this, but it comes in a little pre-filled syringe that you then just unscrew it and attach your cannula. I have several different ones I like. For me, so I've been made fun of already. I have tiny hands, okay, so I can go ahead and make fun of myself on here too. I have baby hands, all right? So I'm like the little Saturday Night Live baby hands girl, right, Noreen? I'll never live it down, it's fine. But anyway, for me, it matters a whole lot on what cannula I use, because I don't have a lot of space right here. So if you're like me and you have baby hands and you can admit it, the pediatric cannula work great because they're short, right? And so I'm able to get in there. I do also probably prime the cannula a little bit more than somebody else might, just because I don't want to hold it here. I want to hold it here. So I probably do waste a little bit, but that's okay. But I go ahead and prime it really nicely, and then I prefer the straight cannula. And I've been using 25 the most. I talked to my friend Selena out of, I already forgot, Missouri, I think she is, and she likes the 23. So if you have the opposite problem, if you have the problem of it's harder for you to push, if you go to the larger gauge, smaller number cannula, so like a 23, it's actually really easy to push. And so she found that she really liked 23. Just with that, you're going to dilate a lot more puncta to get in there. So it's just, you know, get started, and you'll figure out your jam. She also likes to do it with the slit lamp. I like doing it freestanding. Same kind of thing. Play around with that. They're both easy. You could do it either way.
Yeah, I like loops as well. For me, it's just
loops
easier
are just great. And I can be where I want to be then. I don't have to be fumbling behind the slit lamp.
Yeah. And I like the patient when they're sitting back too. For me, they're more relaxed, so it's easier for me as opposed to them trying to shove their head in the slit lamp with the bright light.
Exactly.
Yep. So, cool. You and I are the same on that one.
Love it.
Right. And we're good. I also like to prime. When I prime, I That's when I squirt a little bit on
And show them.
on their fingers, and hey, here's your fingers, and let me put a little bit on and make sure that nothing touches, so we're not contaminating. But it just, when you can touch and feel,
it makes it less scary.
Exactly, right. It takes the mystery out of it, and they're like, oh, they're just this. So for those who before used to have the silicone plugs and right, that they were put in, how do you describe what you're doing with the Lacrifill gel as opposed to what you were doing before?
I just explained that I'm going to fill it up. So instead of using a plug that's just going to kind of sit on the front part of the system, I'm going to use this gel to fill it up completely. And so I explained to them that for the most part that's going to last about 6 months, and if this is working great for you, we'll just go ahead and plan on it. About 6 months we'll do this again. At any point though, if you start to feel like it was going great but it's wearing off, we are allowed to do this whenever we need to. So go ahead and tell them that. That way if 3 months from now they're feeling symptomatic, they don't feel like they have to wait like some timer's being set. But I also explain the reverse. Like if for any reason we want this out of here, I'll do this exact same thing only with saline, and I'll just flush it right out. And so I feel like you take all the worries away by just kind of explaining all the what ifs.
Yep.
So that's what I say.
Well, it's perfectly addressing the human behavior, right? We're afraid of everything as part of our survival.
We are manipulating the expectations in that scenario.
Ooh, I like that. You need to write a book. Right.
I have like 3 just ready for me to write. It's just the time part, right?
Well, when you do, I want the signed copy.
Let's do it. All right.
Yeah.
If you give me the good mic next time.
There you go. Good mic. Yeah. I forgot my super cool podcast microphone. So, but this will work well.
That's great.
Cool. So when for some of the nuances, and I know I am sometimes a little hesitant to try something new on a patient that I haven't tried and played with, right? So when we got this, the first thing I did is, sat my partner and the rest of the team down in the office. I'm like, guess what? Plugs for Lacrifill for everybody, right?
Right.
And quickly it was a non-issue. You're like, oh, this is easy, right? And then I started handing it to, my interns and whatnot. I'm like, here, you guys do this, right? Play with it. So what are some kind of tricks or things that you've picked up on while you're doing, other than the using the pediatric cannula?
Yeah,
and,
so each
23 gauge?
cannula has a completely different squeeze, and so get the feel for it before you get started, right? Because once you get in there, it's a lot harder to figure out, like, okay, how hard do I have to press, that kind of thing. So definitely when you're priming, pay attention to how hard you have to squeeze. I'm getting a lot better at watching the numbers on the side of the cannula to actually see the gel go in, because I get so focused right on the puncta that I'm not paying attention to, like, am I actually doing anything? And so starting to look at the cannula helps with that. And I feel like just doing it, right? So I did 3 or 4 staff people first before I did a patient. And then what you're finding, right, is the more you do now, I have a staff of 28 that all of a sudden everybody has dry eye and needs this, right? They're all wanting to do it because they all start talking to one another about how great they're feeling. And so I think what we probably undervalue is how simple things to us can make such a difference to our patients. And this is one of those things that kind of reminds me of that, because I'm having 20-somethings come up to me and say, hey, so-and-so is talking about Lacrifill, can I do it? And I'm like, well, yeah. And then you do it, and then the 20-something is coming to you talking about how much better they feel. And it just is almost like a slap on the wrist, like, crap, I really do need to be talking about this to everybody.
The Myopia Collective. CooperVision and the AOA have partnered in a groundbreaking initiative to change the way optometrists in the U.S. treat children with myopia. The purpose of the Myopia Collective is to rally the profession of optometry and its allies to interrupt the status quo and elevate the new standard of care for children with myopia. Every individual is encouraged to become a member of the collective. By joining, you commit to taking action to help slow the progression of myopia in children. You'll receive updates and information about the collective and its work in the fight against myopia, gain access to educational opportunities and resources offered by the collective, and hear from change agents, the ambassador optometrists selected to serve as advocates for community and policy change that facilitates the mission of the collective. Scan the QR code or click on the link in the show notes to join the collective today. In the past, our focus revolved around prescribing MacuHealth or MacuHealth Plus to patients at risk of macular degeneration, while also recommending it to collegiate and professional athletes for enhanced contrast sensitivity in sports performance. However, this year's introduction of the Life Meter has been a game changer. The Life Meter revealed a concerning truth. Many of my patients have alarmingly low skin carotenoid levels, indicating potential deficiencies in essential body tissues like the retina and brain. Supported by over 30 peer-reviewed publications, LifeMeter's accuracy, consistency, and effectiveness has been demonstrated across 2,000 subjects with diverse backgrounds. With this newfound insight, I can now have meaningful conversations about carotenoid levels with all of my patients, even those who may seem outwardly healthy. To learn more about this empowering technology, feel free to contact your MacuHealth representative or click on the link in the show notes. Together, let's optimize patient care and elevate their well-being. No, I agree 100%. And what's really cool about what you just said is that your team's bought in. They understand the value. I've talked to some offices who they'll bring in a device. Let's say they bring in a Lipiflow, right? And they've had it and they can't move. They're not using it. They're worried about it. Aaron, how come nobody's buying into this? And I ask, well, how often does your team have it done? And it's not uncommon where the whole team was like, well, I've never had it done, or I had it done once and it was all right. If your team doesn't believe in it,
Right.
It's really tough for you to sell that because people see it, right? Whenever we've gone to Disney, you can always find that one cast member who just isn't having it.
That's exactly
And
right.
they ruin the magic. So if your team is not on board with it, and if they're not having, the opportunity to do this every 6 months,
Yeah.
right? Should they want to? I mean, I wouldn't force them to. There's probably an HR
Sure, of
violation
course.
somewhere in there. But
Right.
right. But to have them get the benefits of working for you, so they can, one, feel it, but two, share that with others, and that's where a lot of the belief comes from.
That's so true. And it goes to everything that we do. We kind of take for granted that everybody just believes us and trusts what we're doing. But when they can see it, feel it, touch it, then they're right there telling your patients like, oh my goodness, you got to have it done. I had it done and it was great. Regardless of what we're talking about. IPLs, Lacrifill, glasses, whatever.
All that stuff, yeah.
Yeah.
You got to Ted Lasso it. You can't just put up a sign that says believe. You got to believe
That's
and
it.
believe. Yeah. Cool. So when you're filling with the Lacrifill, do you aim to put in so much? How do you know when you're done?
So it actually starts coming back at you. And I think it's about 30% is the stat I'm comfortable with, that you'll actually see a full fill actually go to the superior puncta, which is really cool. If you're staring at the bottom one and then all of a sudden, you start to see stuff
come back
coming
up.
down, look up, right?
Yeah.
Because about 30% you'll actually feel the uppers as well. And I do go ahead and build the uppers if that happens, for anybody who needs to know that. But you will actually see either from the bottom puncta or the top puncta, hyaluronic acid starts to come back at you when you have a full fill.
Gel come back out. Yep.
And if you do it, if you get Lacrifill coming back at you, 2 seconds into your push, that's probably an adjustment. You're probably not quite into the system. And so that's why I also think it's good to look at the cannula and see how much you're putting in, because if you're still kind of where you started, you know that that's what has happened. You need to just get in there a little bit better.
Yep. That's just a little bit of I think your first couple, right?
That's a pro tip. Yeah, it's like doing a couple
Training day
times
for the
and
first
you got
couple,
that
right?
Yeah.
Yep. you get it. Nope, we do the same things, and I kind of like it when you're feeling the uppers too
I think
from the
it's
lower,
awesome.
because
It's like bonus.
going
I
upper
don't have
is
to go
always
up
just
there
good.
and I'm
Yeah.
going to build both. Yeah.
So, no, very cool. What have you noticed from patients though? Because you hated plugs, so maybe this isn't the right question for you.
Yeah.
But the ones that did have plugs before,
so it's
right?
amazing because plugs sucked. And this is amazing. I'm happy. They're happy. Patients get immediate relief. I feel like with plugs, it was almost the opposite. It was either nothing happened or you hated it and you wanted me to remove it, right? It was not people coming back to me being like, oh my goodness, it's so much better. Thank you. This gives a lot of immediate or fast feedback to where patients, even like for a contact lens exam, for instance, I had one where I did it and they were coming back anyway for a contact lens exam, and in that amount of time somebody was saying, I can already really tell a difference. I didn't know how much I was going to notice, but especially like end of the day contact lens wear, I can really tell it.
Yep.
So things like that have been really exciting because I don't feel like it was that exciting with punctal plugs.
No. I'm glad you said that, because we noticed the same thing too. I felt like with plugs and historical occlusion methods, I was asking and trying to elicit you like it, right?
Tell
Don't
me
you
about
feel
it, right?
better?
It's
Don't
great.
you, right? Yeah. Right. Wasn't I a great doctor? Like, you feel better? Whereas is here we had significantly more patients telling us, hey, my eyes are feeling better.
Yes.
And that'll actually lead us real quick into, I know you were just down at SECO, I wasn't there, but I saw some articles on this that our good friend Mili Brujic did a poster
Yeah, I saw that.
on this topic, which I thought was pretty darn cool. And he looked at a handful of patients. I'm going to quote it wrong, so Mili, if you're listening to this, don't feel free to tell me I explained it not quite perfectly, and then would love you have Don to talk more through it. But he just wanted to see what the outcome was, what the cornea looked like, what the patient experience was, right, on the handful of cases that he looked at. And even this little video that was on the article, and I'll link that in the show notes. Right, he was pleasantly surprised that their corneas looked better, that they felt better was really the overall summary outcome.
Right.
And then he hypothesized that was because of the HA,
Yeah.
which makes a lot of sense, right? One, I think because you get, and you've addressed this too, you get a full occlusion. Right? There's not like little ways where it can sneak through, and the tears can sneak through. So you get a full occlusion, but then the HA, over time, like there has to be this small little release of HA, and I don't think that probably was the initial intent,
Right.
but it's certainly a positive benefit. And and if you've got that little release of HA into the tear film, that's going to be positive for the cornea. That's going to help for the corneal rehab. It's going to help for contact lenses comfort and just overall dry eye comfort.
Yeah. No, I agree.
So I'll link that in the notes. I thought it was a pretty cool poster. If you get a chance to see the poster, the before and after images that he showed were pretty
the
impressive.
SPK was probably like grade 4 to grade 1.
Oh yeah, I mean it's
massive improvement.
Yeah, the first ones I would have slapped Procaras on.
I thought the exact same thing.
Yeah, like wow.
Like, what else are we doing for this cornea? Like,
Yeah, I was like, and he'd been. I mean, it wasn't like they were doing nothing. He was putting stuff on them
Yeah.
already. They had him on
Yeah, he
Ribo.
did.
We had him on tears and nutrition and all sorts of the stuff. Right. Mile knows his dry eye stuff.
That's right.
So it was pretty cool. Mile, thanks for sharing that poster. And like I said, I'll link in the notes for anybody to go watch it. But it was, when I had heard about it, they talked about the HA, and my brain never connected the, hey, this is,
right.
yeah, it's good stuff, but I didn't realize it
Good.
would be great stuff.
That's right.
Gooder stuff? Can I say
It's
gooder?
gooder stuff. Yeah.
Gooder stuff. So, very cool. What has using Lacrifill changed how you've addressed patients with dry eyes? Has it changed any of your other therapies? Does it kind of fit just nicely in with them?
So I do a lot of IPL and thermal expression, and I have done Lacrifill on most of those patients, kind of just trying it out, right?
Yeah.
And I feel like patients are feeling better faster. So that has kind of changed my thought process on, okay, somebody who we really want to succeed, they've invested a lot of money in us, what else can we do to get them to comfort quicker? And so that's moved Lacrifill up into my bag of tricks for sure.
So,
Plus, just having an option, like I said, there's so many people who that's not practical, right? Like they can't do IPL, they can't do thermal expression, they can't do an eye drop that costs them hundreds of dollars. And so you really start to run out pretty quick of options for these people.
Yeah.
And so having something that we can say, let's at least start here, let's at least do this, is a game changer in my opinion.
Absolutely. And I think it's, at least for me, it's combated the argument or taken away the argument that I've got to wait until their MMP9 score is low, right? I'm less worried, significantly less worried about the inflammatory markers in the tears.
Yeah, I'm going to address inflammation too, but I'm not going to worry about going ahead and doing this.
I'm not gonna get rid of the inflammation first.
Exactly.
Has kind of changed my thinking as well. Yeah, and I agree. I think that's a it's interesting in the dry eye space, and I think Kyle and Chris have talked about this on other podcast episodes. But for some reason, in optometry, dry eye has become a specialty.
Right.
Whereas, I don't know too many of us that walk around and say, "Well, I'm a glaucoma expert."
Right.
But we've got plenty of dry eye experts, and my argument is basically you should be an optometry expert, right? And an eye care expert. Now, I appreciate that there's certainly some fields that we do better than others.
Right.
If I have a low vision patient, they're going to be referred to a colleague.
That's right.
Vision therapy as well. And I value it, I just don't do it.
Yep.
But I think for primary care and dry eye, for me, falls under that.
Yeah.
It's, you don't have to spend all the money to get all the toys. They're fun.
That's it.
But I do think that having practical options that work very well and have clinical studies behind them that show, but also the just practical experience from colleagues like you and Mila and whatnot that make a difference for patients.
Right.
Right? You don't have to wear a fancy hat and be an expert.
You
just
don't.
practice a little bit, look for some patients, because the speed score costs you how much to incorporate?
That'll cost you nothing.
Costs you nothing, right?
That's it.
Right. Coming up with a to-do checklist is pretty easy, right? You can follow dues and adapt it to your market. And Brian Holman, if you're listening, I don't know where banana sandwiches fall into that, but you might have to add that on yours.
Eat one while you're making your protocol.
But blink more, go outside more, drink more water, right?
Right.
And are all practical things. I think we all clearly understand the value of omegas and warm compresses. The only other thing I add that you didn't mention is lid hygiene. I think it's a
that's right.
huge issue. So we sell a lot of the Peak Pro little foaming cleansers. Just enough tea tree oil that it kind of tingles and feels good. By the way, the last time I got yelled at by my wife and daughters at the same time was when they ran out of Peak Pro and I didn't bring any more home from the office.
Oh, yeah.
Because that's a definite, it helps really good for acne.
So I was going to tell you the same thing. So my son is 13, and we have found that is one of the best things that we can do.
Yeah.
Yeah.
Oh yeah. It's and Lord help you if they try to steal the other ones, because then the fight is who stole my Peak Pro.
We're not there yet, thank goodness.
No.
Just have the one.
Funny things that happen in the home of an optometrist, right? Where's my Peak Pro? But that's the only other thing we add. So we definitely do the warm compress and the omegas, and then bring them back. But I think that if you're wanting to get into this and you don't feel like you have to have all the fancy toys.
Well, that's it. And if you want to build a dry eye practice, if you want to see more of this, all you got to do is start looking and start doing something like a Lacrifill, make people feel better, build the patient base. And then if you want to buy a toy, go for it. But you don't have to feel like you have to own all the toys to treat dry eye. You really can just get started.
Absolutely. And it reimburses well.
It does. It
Right.
does.
So probably more than some of the other diagnostic tests that we
No, exactly.
that we
Here,
do.
I think it's average $220-ish per, the first two, and I think it adds up half for the, if you end up doing all four. I think that's right. So not bad money for, a couple minutes time.
No, not at all. And you're taking care of the patient first and foremost, but it's certainly
That's right.
taking care of the practice. And then, if you don't have your NIDEC or your Oculus or whatever to take images, right, a cell phone, right, throw some fluorescein stain in. You can take a cell phone fluorescein picture. There's little adapters you can get on Amazon for pretty cheap that take it. So it's really easy to build up to a full-fledged dry eye clinic if that's what you want, or just take care of the patients that you have.
Exactly.
And decide where to go. But I think taking care of them first and foremost is the most important piece. And then when we've got new technology and new things to use that work, which are important,
Yeah,
it helps as
exactly.
well. So awesome. Well, Jenny, what else are we missing on this discussion?
I don't know. I feel like you hit it. I think it's as simple as just get started. Lacrifill is running some really great promos, I think, to get people going, and a pack of 10 costs you next to nothing to try it out and see what you think.
Yep. Nope. I fully agree. Good company, good people.
Yeah, they're doing great.
Yeah, if you know Todd Love, he's fantastic and a lot of fun, but also I've known him never to jump into anything that he doesn't believe in.
That's exactly
And,
right. That whole team has been amazing, and I think they have a great group and a great philosophy, and they take good care of you.
Yep, absolutely. So jump into it. It's whenever there's something new and novel that comes out, I love being able to dive into it, especially if it's highly valuable. Even more fun when I get to call on a friend and not get yelled at too much that it's taken this long to get you on here.
It's all good. Nothing but love.
That's is that the millennial heart? We were trying to do like the little
This
kid
is the
heart.
old, yeah. This is the old school people heart. They have a new one. I don't know. I can't do the new one, but
I couldn't either. We were trying it in the office the other day. Only my extern could do it. I can do that one, or my kids taught me with like the 2-finger.
yeah, I got nothing.
Little,
I just gotta go old school. All right, that's the one I
old
got.
school big heart. So if you're listening to this and you know how to do the new heart,
That's right.
let us know. Send me a picture or tutorial so I can figure out how to do it. And,
Send me a TikTok. I won't know how to open.
yeah, I don't have TikTok. I use text.
Exactly.
Now my kids are like voice texting me. They don't even type it. I just have to listen to the voice message.
Yeah, my
And
son
then it
is
goes
already
away.
trying to do that stuff that's like a K, and I'm like, no. Let's stop that now at 13. You text your mama in full thoughts.
Yeah. Do you edit your kids' texts? Like when they aren't grammatically correct, I'll edit mine and make them send it.
I try not to.
Yeah.
But yeah,
I'm no longer cool dad.
I'm definitely not cool mom. Far from it.
Awesome, Jenny. Well, I appreciate your time. Again, in the notes, we'll put in the link to the article about the poster that Emilia Brujic did and presented at SECO. We'll have some information for the company if you're interested in there. But I think really my biggest takeaway is just look at your dry eye practice. I know Chris and Kyle talk a lot through Comprehensive Optometry Simplified on building that pillar, but you spelled this out very clearly at the beginning, Jenny, on just how methodical and intentional, right? And manipulative, but how methodical and intentional. Doesn't that sound good? More positive? Yeah. Intentional in everything you do, and with a team of 28, you got to be intentional. You've got to be clear. You cannot grow and manage that number of people without correct processes and steps in place.
Sure.
And just listening to you, I think it became very clear that you've done an excellent job in that.
Oh, I appreciate that.
So kudos. Awesome. We'll look forward to seeing you in not too long out in Denver at the Vision Source Exchange if we don't run across each other before then.
It'll be here in just a minute. Great
It
talking
will
to
be.
you.
Thanks, Jenny.